Hello and welcome everybody to our webinar today, Humanizing Your Enabling Services Data for Patient Care, Implementation Strategies. My name is Danielle Rahajasan and I am the Administrative Coordinator at the National Center for Medical Legal Partnership. I will be running technical assistance on this webinar today. In just a moment, I will turn this presentation over to our panelists for further introductions. Before that, I have a few small housekeeping things I would like to run through with everyone. Because we have a large number of participants on this webinar today, everyone joined in muted and will remain so throughout the webinar. However, you will be able to unmute yourselves during any activities or office hours, which will take place right after the presentations. On your sidebar of this platform, you should all see in the list of drop-down options a space entitled Questions. If throughout the webinar you have questions, please type that in and send it in that space. There will be a brief survey that will launch at the end of this webinar. Your participation in this survey is greatly appreciated. It won't take more than 2-3 minutes to fill it out. Today, we also have two great handouts for you, which you should be able to see in the handout section of your sidebar as well. Last but not least, if we encounter technical difficulties on our end or yours, don't worry. The audio is available to all registered participants after the webinar concludes. And for that, you can visit the SDOHacademy.com website, where all of that will be available, as well as additional resources. So without further ado, I will now pass it on to Darlene.
Great. Thank you so much, Danielle. Good morning and good afternoon to everyone who's joining us today. Before we get started, we'd like to just take a quick poll to see who is in the audience today. So will you please answer this question? Did you attend session 1 of this Humanizing Your Enabling Services Data for Patient Care Learning Collaborative? If you joined us last session, which was on February 12th, please say yes, indicate yes. And if you were unable to make that session, please indicate no. And if you had signed up but you were not able to make it or did not even register, you can say I wish. So please indicate the correct answer at this time. Danielle, if you can give me an indication.
About 85% of you have voted so far. Votes are still coming in.
Okay. Again, if you were able to join us on February 12th, put yes. If you were not able to join us on during that time, put no. And if you did not register, you were not aware of that session, please put I wish.
Yeah, we have 95% of people have voted so far.
Okay. For those who are still deciding, if you could quickly get those votes in, then we can move on. How are we doing, Danielle?
I can close the poll now.
Okay, great. Thank you.
Mm-hmm.
Wonderful. Okay. And we see the results. So we have 50% who were with us on our first session and 31 no. And then we have those who are new, who probably didn't register at all, 90%. So thank you so much for participating in that poll. It gives us a better idea of just who is in our audience. So we really appreciate the responses. Next slide, please. So again, we like to just kind of review of the purpose for this learning collaborative and the target audience. I want to just remind everyone that as we begin this second session, that everyone is welcome to participate in the learning collaborative, but just be aware that our target audience and the material has been really planned to meet the educational needs of staff from health centers, primary care associations, and health-centered control networks. The time commitment, each of our learning collaborative sessions include a 90-minute session. So we did 90 minutes on February 12th. This is our second 90-minute session. We do 60 minutes in presenting and training, and then it's followed by 30 minutes of office hours where you are able to ask questions. You're also able to put questions in the chat box. We really like to encourage you to take advantage of these office hours. Your phones will be unmuted and you'll be able to ask questions and talk and share information between participants. So please take advantage of these office hours. And then there is a registration. You can register for any of the remaining learning collaborative sessions, and the link will be on the at the end of this presentation, and we'll also put it in the chat box so that you can have access to that. And then all of our trainings are recorded, and they will be available afterward under the SDOH trainings tab on the SDOH Academy website, and we'll also give you the link to that. Next slide, please. So these learning series, or the learning collaboratives, are really a planned activity, and is based on the collaboration of 16 national organizations that have national cooperative agreements with HRSA. And here you see the logos of the 16 representatives, and throughout the learning collaborative sessions, you will be hearing representatives from each of these organizations presenting. Next slide, please. Here's a listing of all of the learning collaboratives that are being planned, and as we mentioned before, this is the first learning collaborative. We're in our second session. Then the next learning collaborative will start in March, and there's 2 sessions there. The third will be in April, and the fourth will be in May. You are encouraged to register for as many as you are able to participate in. So you're not limited to having to pick one or two. You can select as many of the sessions as you are able to attend, or if you're interested in receiving the recordings, please register as well for that. Next slide, please. These are the core competencies of the Learning Collaborative series. As we came together, the 16 organizations came together to plan this series, we really want to ensure that we are giving the participants some very substantial core competencies that they can take away from after participating in this series. And so the core competencies are as follows. We want to have individuals improve or learn how to improve access to quality healthcare and services. We want to foster a healthcare workforce that are able to address current and emerging needs. We want to enhance population health and address health disparities through community partnerships. And then also one of the core competencies that we're really trying to ensure that we're addressing is understanding some of the emerging issues. So these are the competencies that we would like for everyone to really be able to have an increased knowledge of by participating in these series. Next slide, please. These are our presenters for today. I am Darlene Jenkins from the National Healthcare for the Homeless Council. I'm serving as your moderator. Then our next speaker will be Albert Ayson from the Association of Asian Pacific Community Health Organizations. Following Albert will be, Michelle Jester will be our first speaker. Michelle is from the National Association of Community Health Centers. Then our next speaker will be Albert from the Association of Asian Pacific Community Health Organizations. Following Albert will be Kristina Wharton. She is with the Health Outreach Partners. And then we will all and we all will share in the office hours. And joining us at that time will be Joe Lee from the Association of Asian Pacific Community Health Organizations and Cindy Selmi. So we are hoping that you will enjoy this presentation. Feel free to put your questions again in the chat box. And when our phones are unmuted, we really encourage you to speak up and share any information you would like for us to know. So without further ado, I'd like to turn it over to Michelle. Michelle? Oh, I'm sorry. I didn't do our learning objectives for this session. Let me go back to that next slide, please. Before I turn it over to Michelle, let me just say that, so we went over the core competencies. The next slide shows the learning objectives for this particular webinar series that we did for the learning, for this learning collaborative. It's really focusing on enabling services and helping you understand how to build capacity. We will be discussing or have discussed health information technology and then explain the importance of application of enabling services data for social determinants of health. Next slide, please. I want to remind that there are two handouts that have been attached in the area just above your the chat box. So please access those. And if you're having difficulty, just let us know. But these are two very important documents. One in particular, I'd like to just bring your attention to, it was recommended on our last session that we have a sheet for key terms as well as for acronyms, and so that has been provided for you. So we hope that will be very helpful. So without further ado, I think it is time now for Michelle. Thank you.
Great. Thank you so much, Darlene, and welcome everyone. I want to thank everyone for filling out the poll. It's really helpful to know how many of you were with us in our last session, how many of you are joining us for the first time. So welcome to everyone. But it was helpful to see that actually 50% of you guys were with us last time, but then the other 50% are joining us for the first time. So I did want to spend a little bit of a time recapping what we discussed in our previous webinar. And then we will be doing more deep dive into both how do you collect standardized data on social determinants of health and enabling services, and we'll provide some case study examples of how you can really apply this in your own practice. So next slide, please. So just to kind of recap, a main topic that we covered in our previous webinar, and just a good reminder for everyone that we're at a point where it's really important to collect standardized data on both the social determinants of health and enabling services. Many of you are likely already focusing on social determinants, and obviously many of you are providing enabling services, given that your mission and that your health center model. But without standardized data, it's just really hard to systematize and then really streamline this work into workflow, be able to aggregate that information to really inform the needs of your population and where your organization should be thinking about strategically. But then also to demonstrate health center value in all of the work that you guys are doing, but may not be currently reimbursable. So just to quickly recap how standardized data on both social determinants of health and enabling services can be useful to you. At an individual level, having that information really helps you better understand your patient populations and what their needs are. That can automatically inform the care and treatment plan that is provided at the point of care. Same with enabling services. If you're able to track what you're providing at an individual level, that will really help you determine what interventions might work best for which kinds of populations and which kind of settings. So at an organizational level, being able to aggregate both the standardized data on the needs of your population and then what you're doing to address those needs, it can really help you think about how you should streamline your services, potentially how you should redesign your care team. Should you add more non-clinical staff to your care team? Should you potentially adapt your workflow to incorporate more of this non-clinical work? So it's really helpful to have that information to paint that picture for you. At a larger system and community level, again, having the standardized data on the needs of your population can really help inform the cross-sector partnerships you might consider forming or you might consider strengthening. So working with the housing sector, transportation sector, education sector, things of that nature. And then finally, as I kind of mentioned before, at a larger payer and policy level, we really want to help you have that data that you need to best tell your story, to better demonstrate just how complex your patients are, but then all of the things that you guys are doing to address the needs of your population. But to do that, you need different kinds of payment systems to really help incentivize and sustain that non-clinical work. Next slide, please. So at our last session on February 12th, we covered a couple of different tools to really help you collect standardized data on both the social determinants of health and enabling services. One is PRAPARE, which is a national standardized social determinants of health assessment tool that is built into multiple electronic health records. And it's really meant to be patient-centered. It's meant to really help you have a conversation with your patients. This was developed by us at NAC, so the National Association of Community Health Centers, along with AAPCHO, the Association of Asian Pacific Community Health Organizations, and the Oregon Primary Care Association. And we're thrilled to say that it is the most common social determinants of health screening tool used by health centers, but then also Medicaid managed care organizations, which is very exciting. And it's increasingly being used by others in the health system, such as hospitals, payers, plans, and so forth. We also covered the Enabling Services Accountability Project, which is a standardized codification system to really help you document the enabling services that you are provided. And this toolkit was developed by AAPCHO, so again, the Association of Asian Pacific Community Health Organizations, and both AAPCHO and HOPS, Health Outreach Partners, provide great training on that as well. So underpinning all of these standardized tools are standardized codification sets. So let's go to the next slide, please. So if we really want to think about the importance of standardized data, it's really important to have codes associated with the data. This is really helpful that if you are an individual health center, but you belong to a state primary care association or a regional health center controlled network, you and your other colleagues may be on different electronic health record systems. Therefore, that makes it harder for a PCA or a network to be able to more easily aggregate and pull the data out of each of your respected electronic health record systems. However, if we have standardized codification sets that underlie everything that we're collecting, that really helps with aggregation, it helps with analysis, and it helps with interoperability. Maybe you're participating in a state health information exchange, or maybe you're part of an accountable care organization. Again, many of you may use different tools or you may use different questions, but again, as long as we have these standardized codification sets to kind of underlie everything that we're collecting, that really allows for local customization, but then more national standardization. So just to let everyone know, we got a couple questions on this at our last session, so just kind of wanted to provide a little more information. We have mapped PRAPARE data to 3 standardized codification sets that are commonly used. One is the ICD-10 Z code list. So for those who aren't familiar, in the last iteration of ICD, so ICD-10, a new set of codes called Z codes were added that were meant to help capture information around socioeconomic circumstances and social risk. So that is a common codification structure that is commonly used across different organizations. So we map PRAPARE to that. You will notice that there are some gaps in ICD-10 Z codes. Like, for instance, there's no Z code for transportation and some other key social determinants. But we have mapped it to where it exists, and we have worked with some other partners, including United Health Plan, to recommend additional Z codes to the ICD committee that are under review currently to try to help fill those gaps. In addition to Z codes, we've also mapped PRAPARE to LOINC codes, and we've gotten new LOINC codes added to fill in gaps where they existed, such that everything in PRAPARE is mapped to a LOINC code. And we've also mapped PRAPARE to SNOMED codes. So you can see this data mapping. We have it in our data documentation, which is part of our toolkit, which you can see on our website there, but just wanted to kind of underpin that for everyone. Next slide, please. So if we're thinking about strategizing social determinants of health data collection, it's really helpful to use what we call a 5 rights framework. Many of you may be familiar with this already, but a 5 rights framework really helps walk you through those key questions of who, how, when, where, and what, to think about how you might strategize implementation to your own workflow. So when thinking about collecting standardized data on social determinants of health, it's helpful to think about what? So the right information. So think about what information in PRAPARE are you already collecting? As you look at PRAPARE, you'll notice that a lot of it is demographic information, and that was intentional because we wanted to provide you with that full socioeconomic picture of your patient. But many of you may already be collecting some of that data as part of registration. And so we don't want you to double document or have to ask the same question multiple times. So with many of the PRAPARE EHR templates, it should automatically map to your practice management system or your registration and pull that data into the PRAPARE template. But it's helpful to think about maybe you're using other health assessment tools, or maybe you're involved in other initiatives that may require to ask similar questions. But it's just helpful to kind of think about what questions are you already asking around social determinants, and is there a way that either PRAPARE can add value because maybe you're currently just collecting it on paper forms and PRAPARE can help put it into the EHR, or other ways that maybe the information really just enhances each other. The next thing to think about is how are you going to collect this information? So what is the right format for this? Would you prefer that patients self-assess, so fill out something on their own to give them a little more privacy? Or would you prefer that a staff person discusses this with your patients to have that patient-centered conversation and provide that active listening and, empathetic listening as well? There's no right or wrong way. It's more just a matter of what fits best in your own setting, but things to think about. The next thing to think about is who. So who is the right person to collect the data, and who is the right person to respond to needs identified? Would you prefer that your clinical staff or your providers do this so that they can immediately incorporate that into the care plan? Or would you prefer that non-clinical staff do this because they often have the knowledge and about the resources in your community? Again, no right or wrong answer, but just something to think about. The right time. So when is the best time to collect this information? Would you prefer that this happen before the visit with the provider so that, again, this information can help inform the care and treatment plan? Would you prefer that it's after the visit, that you want to make sure you're not delaying anything to keep the patient away from the provider, so you would just prefer to do this after the visit? And then finally, think about right place. So where is the best place to collect this information? Is your waiting room conducive for someone to either fill something out on their own or for someone to have a conversation with the patient? Or would you prefer using private offices and whatnot? Next slide, please. So as you think about these 5 rights, you can then use that to help map out your workflow. So these are just some sample workflow models for PRAPARE data collection. Again, there's no right or wrong way. There are trade-offs and advantages to each of these models. But again, there's some reasons why you may want to use one over the other. So again, for non-clinical staff, these are often staff who are very well aware of the resources in the community, so they would be great assets on being able to respond to the needs identified. They might be able to fit it in their workflow because they might be working on similar responsibilities. Clinical staff. Some people prefer to use clinical staff because they already have the professional training to collect sensitive information because they often already are collecting it on depression screenings and whatnot. They may be able to do this as they're taking vitals. I'm sure as you remember going to the doctor recently, they often ask you several questions as they're taking your vitals. So that's another possibility. If you have care coordinators or care managers, obviously they are working with people and doing the best they can to help manage their care. So they're often asking other health risk assessment type questions or care management type questions. So it might be a good way to integrate PRAPARE into that, and that way you can use that information to help inform the care plan. Some choose to use what they call a no wrong door approach, where any staff, from the front desk staff to providers, could play a part in collecting data on social determinants of health. That's a great way to get everyone involved, and people seem to really appreciate being able to do something for the patient. If you do use this approach, you just have to be very strategic and careful that you have a clearly mapped out plan and that everything is well communicated and everyone knows what their responsibilities are, so that you don't run into the issue of the patient getting asked the same question multiple times, because that's just not patient-centered. And then finally, we've discussed self-administration, where a patient would fill it out. And that's a great way to collect a lot of data in a short amount of time. So you could potentially use your patient portal or send it out, via email beforehand. But we would just definitely advocate that if you do use that approach, that when the patient does come in, or that there is some follow-up, to then have that conversation to discuss the needs that were identified. Next slide, please. Just so everyone knows, we had a couple questions about this in our previous session on February 12th, but we do walk through each of these workflows. They are all available in Chapter 5 of the Toolkit, and you can see the website there. But we map out each of the workflows. We kind of talk about the reasons why you may consider using this model, and then again, the advantages of the model and then the trade-offs, so that you can hopefully help decide what might work best in your own setting. Next slide, please. Just really quickly, something to think about is how the population of focus may affect your workflow model. So that's always a good starting point as well when you're thinking about those 5 rights, is who you want to start with. Some of you may want to start with all patients, which is amazing, but many of you, I'm sure, will probably want to start with a smaller population just to test it out, see how it fits in your workflow, and then see if there are any tweaks that need to be made, kind of like in a PDSA cycle. So if you are choosing to start small, the population of focus you choose may potentially dictate your workflow model, such that if you're focusing on patients with chronic disease, it may make sense for your care management team to be the one to administer PRAPARE as well. Similarly, if you're focusing with behavioral health conditions, then maybe it's your behavioral health specialists that are doing it, and so on. But something to think about is that I know it sounds like a lot, and we don't want to trivialize that, but think about how you can utilize your current staff as opposed to thinking that you need new staff. And in many cases, a lot of times it's just thinking about how you can cross-train your staff. So if you have like outreach and enrollment staff, or if you have patient navigators or community health workers, in many cases, a lot of their responsibilities, especially when it comes to social determinants of health, are similar. And so it's just a matter of providing a little additional training so that they have those skill sets needed to administer something like PRAPARE. And oftentimes staff really appreciate getting that extra professional development as well. So it's just something to think about. Next slide, please. So let's apply this to a case study. So this can help think about your 5 rights, and then also how the population of focus affects your workflow model. So in this case study, you have your general population, which is on the left, and you decide that you would like to focus on your diabetic population because you're having some trouble meeting the outcomes that you're ultimately hoping to have with that population. So you start segmenting that into your diabetic population. You segment that population into further by focusing on your uncontrolled diabetics. So in the middle, you can see that the orange dots are your diabetic population, and the tealish dots are your uncontrolled diabetics. So then, because you're focusing on your uncontrolled diabetics, again, they're likely seeing a care manager or a chronic disease management team. So that helps dictate your workflow model of who would administer PRAPARE with this population. And after administering PRAPARE, they can reveal that many of these patients who are in your uncontrolled diabetic population have unfortunately missed some appointments, but it's not because they purposely missed it. It's because they had transportation issues that prevented them from being able to get to the clinic. Or you discover that several of them live in a similar area where it really is a food desert, and so they really have no accessibility for healthy foods and vegetables. And so that really allows you to then think about, okay, what are the types of services or interventions can we be providing in-house? Can we start a food drive, or do we already have a farmer's market? Is there something that we can do to provide like a prescription program for that? Or it also helps you think about, okay, what else can we be doing to partner outside of our health center as well? So things to think about, should you be advocating for more bus routes to these areas that are experiencing transportation issues, or can you start a mobile van service, things like that. So just having that information really helps you think about how you can plan both internally and externally as well. Next slide, please. Just to reiterate, we have lots of great free resources on our website. Many of you asked about that at our last session, so feel free to visit. We have our free PRAPARE Implementation Action Toolkit, which all the chapters are listed on the right side of the screen, so you can see how we really are trying to walk you through all the steps you need in order to implement it. There you can also find our EHR template links. We have lots of recorded webinars that do an even deeper dive on many of these topics, so I encourage you to check those out. And we also have some other case studies and user stories that might be helpful for you. Finally, last slide, please. So before I turn it over to my colleague Albert at AAPCHO, I do also kind of want to let you guys know about applying the 5 Right framework to also thinking about how you would respond to the social determinant needs identified. So Albert will go into more detail on enabling services documentation from that perspective, but just to kind of get you guys thinking, you can apply the same framework to thinking about how you might respond to needs. So right information. So think about what information resources do you guys already have at your organization that you could provide as either referrals or services, things that you could offer your patients once a need is identified. So I'm sure many of you have a community resource guide as part of PCMH, but how up to date is that? Something for you guys to think about. Are there other things that could be added to that list once you are identifying the needs of your community? The next thing is the right format. So how are you going to have that information stored and how are you going to use it? Is it going to be like a printable resource that you give to patients to take with them? Is it going to be a searchable database that can be easy to find, or will it be a warm handoff for the referrals? Next thing to think about is the right person. So who is going to be this person who is providing the resources or helping the patient respond to needs? Would you like it by just one dedicated staff person or staff team? Would you prefer that any staff person who administers PRAPARE can be the one to also respond to needs? Or would you prefer that the provider do it? Again, no right or wrong, it's just something for you guys to think about. And then finally, right time, so when will these referrals take place? Would you want them to take place immediately after the need is identified? Or would you prefer that it occurs after the patient sees the provider or at the end of the visit? And then finally, where will the referral take place? Again, would this take place in a private office to have a conversation or in the exam room as part of the visit? So things for you guys to think about, and hopefully this provides some more information to really help you guys think about strategizing both social determinants and enabling services data collection. But to do more deep dive on enabling services data collection, I'm going to turn it over to my colleague, Albert.
All right. Hi, thanks, Michelle, so much for presenting the recap on social determinants. And I wasn't able to join you all for session 1, but my colleague, Jolie from AAPCHO, was able to present on that session on the overview of AAPCHO's Enabling Services Accountability Project, as well as an overview of the Enabling Services Data Collection Implementation Toolkit that has been co-developed by Health Outreach Partners and our partners at the National Healthcare for the Homeless Council. And so I wanted to now do a deep dive with you all, since that's kind of the focus of our session for today. And some of you may already be documenting your enabling services data in a standardized way, and then others of you may be interested in exploring it. And so wanted to give you a kind of a teaser and preview of some of the scenarios and implementation guides that are available in the toolkit available on AAPCHO's website. So next slide, please. So just a quick level setting on definitions, and I believe Kristina from Health Outreach Partners had presented this from session 1. But for enabling services, we define it as the non-clinical services that are linked to medical encounter or the provision of medical services for patients at your health center. So quote unquote, enabling your patients to really improve their access to care and also improving their health outcomes. And really the current here is just really collecting standardized data on it so that you can track it over time. That way you can use it for better redesign of your care delivery models, but also for some of the local, state, or national evaluation and advocacy efforts that you may be embarking on, especially as a lot of your health centers or primary care associations, HCCNs are talking about value-based healthcare transformation. A lot of this talk about standardized data for social determinants and enabling services are really key to demonstrating that value for those payers and policymakers at the, again, local, state, or federal levels. In terms of these 15 categories of services, these have been vetted and validated by steering committee members made up of health centers and some primary care associations. It was last updated in 2017, and that toolkit is, again, extensive with just a lot of different worksheets and areas that you can do a lot of self-implementation if you haven't already. And we encourage you all to, again, think about your workflows, as Michelle had just mentioned earlier, about documenting and providing interventions as a response to your social determinants of health needs. And I'll actually give you all a sample of some of these definitions in the following slides. But for just current context, again, we have very limited data or fragmented data available on the impact of enabling services on some of your quality improvement or health outcomes work for the health center. And this is mainly because the value of enabling services has not been demonstrated through existing standardized data. And so this is the justification for why we want all health centers to be able to document very discreetly how much of these ES services they're providing on a volume level, and then also from an intensity level, how many minutes on average are your enabling services staff providing, for example, health education with a patient. By doing a lot of these analyses of your enabling services data, you'll be able to see if you are maximizing your staff's resources and their licensure, so that way they can meet the needs of your patients. And so I'll provide an example in the case study later on as well to really show how this data can be usable and actionable. And then lastly, another big factor in the context of what we're operating now is that enabling services have not been reimbursed or adequately funded by payers. A lot of it has been just grant funded or temporarily funded through some of your funding mechanisms at the state or local level, but we haven't really figured out a sustainable way to pay for our enabling services workforce who are really providing frontline services for your patients, especially around social determinants of health. Next slide. So this might look familiar to some of you who attended session 1. This is a juxtaposition of the old enabling services categories that were originally developed in 2007 with the pilot project. And then in the middle are the revised categories that were, again, vetted through a steering committee in 2016 and 17. And so we have these codes on the right-hand side that are serving as quote unquote dummy codes. That way you can actually on the back end and reporting end look at data and trend data over time for your health center as you collect some of these discrete categories in your EHR or even through paper or Excel. We have some health centers who are doing it very well and have been doing it for a decade. And I know that my colleague Joe had presented some of those case scenarios from Colorado, Hawaii, New York, and California, where they have been very good about standardizing some of their data for enabling services. And then next slide. This is just the additional categories since we couldn't fit it in on one slide. So this is, again, outreach, transportation that have been teased out from outreach to inreach, and then transportation was teased out to become health versus social services, just because there were health centers that felt like they wanted to distinguish their medical versus their social service referrals and transportation services. So just for you all to kind of get exposed to and become familiar with, it'll be helpful for the interactive activity that we'll actually do in a few minutes. Next slide, please. All right, so as I mentioned, I want to give you just an example of definitions that you can find in the toolkit. So for social services assessment, we define this as a non-medical assessment that includes the use of an instrument measuring socioeconomic status, wellness, or non-medical health status. So that could be the PRAPARE tool, that could be the Accountable Healthcare Communities tool, or whatever social risk screening tool that you may be using to assess housing, food, transportation, medical, legal needs, etc. And I have an example here. It does not include HIV testing, cancer screenings. So just want to make sure that's distinguished. Next slide. Interpretation, which is a huge enabling service that a lot of your health centers provide, but may not be documenting, again, the volume or intensity of it. And so in our, I'm sorry, there's a car outside. In terms of the definition, interpretation we define as the provision of interpreter services by a third party other than the service provider, your health center, basically. And it's intended to reduce barriers to limited English proficiency of a patient, and it also helps document the limitations in writing or speaking skills that are sufficient to affect the health outcomes of your patient. So again, an example of interpretation includes interpretation between a patient and healthcare or social service provider, providing sign language during a health education workshop, interpreting over the phone for a physician at a hospital or for a health center patient, and then also translations of medication instructions, etc. In terms of what this does not include is interpreting a GED material that can really be categorized as another category. It does not include providing health education in a patient's own language. This really should be marked as health education provided in another language. And interpretation does not include translating an electric bill for a health center patient. Again, this example should be marked as other. So there's an other category in our enabling services implementation toolkit for anything that doesn't fall in the other 14 definitions and categories, which again, you will find in the packet. Next slide. And my last example I want to share is transportation for social services. So we define that as providing transportation assistance either directly or through a referral to a patient requiring transportation as they receive some of their social service, like again, housing, transportation, food insecurity, etc. What this includes are van services to and from a social service appointment, or enrolling patients in a transportation voucher or assistance program, and transportation service to a soup kitchen or food shelter, and food and homeless shelter. What this does not include is providing reimbursement for a patient's transportation or taxi fare. And again, in the asterisk here, participants are really encouraged to just log the distribution of transportation resources, such as vouchers, bus tokens, taxi fares, in order to really track your use and utilization as you make the case and justification for having more transportation services in your local or state areas. So those are just 3 examples I wanted to share, and the full list again is available. And in the handout that Danielle was able to upload to GoToWebinar, that actually has all 15 codes, definitions, and the inclusion and exclusion examples that I just mentioned. So please download that and review it. It's really just a snapshot and brief handout for you all to kind of think about what else you might be providing around enabling services. We're always looking to expand these, but for now, the 15 have been kind of vetted through our health center stakeholders. All right, let's go to the next slide and get some practice in, since this is a deep dive. Before I do the interactive activity, again, documentation can be electronic or paper. We encourage electronic these days, as most of you all have an EHR or EMR. And then in terms of workflows, there are different types of workflows, especially as Michelle had mentioned, like you have different types of staff, frontline or behind the scenes admin. So really think about who are your champions in the health center to really track and document data and getting buy-in from all levels of the health center organization. And in the handout that you have as well, you'll see some examples of some demographic data that you might collect in addition to your enabling services categories and codes. So those could be really auto-populated already from your AHR. So your patient's date of birth, their gender, their patient ID, the service states, And the two at the bottom here that I want to highlight, encounter type, those are just 3 types that we have selected and are most common. So the face-to-face enabling services visits, a telephone enabling services encounter, and then offsite. That could be in the community through like an outreach and mobile clinic. And then for your health center patients who have a language other than English, we really want to emphasize collecting information on their specified or preferred language. And so our scenario toolkit has some of these fields that you can document. Next slide, please. Quickly reviewing, this is what Joe had mentioned in session 1. Our documentation criteria really does have some specific directions on what counts or doesn't count as an enabling services. So again, it has to be provided by your health center. It's linked to a medical patient at your health center, so patient ID. It's provided to the patient or their primary caregiver. It lasts at least 10 minutes or longer, and we have 10-minute increments that we propose in order to make it easy to document. And then the service really should be documented on an encounter form or in your EHR, 1 per patient per encounter per provider. So for example, if you are providing health education and case management referral services to 1 patient during 1 encounter, you should just document both services, both the health education and case management, on the same encounter form on paper or in your EHR. So that way it's consolidated and not fragmented as you look back at some of this information. All right, next slide. Okay, as I mentioned, the 10-minute increments, those are going to be key for the next exercise when you think about the number of minutes a service is provided to a patient. And I have 3 scenarios that I want to present to you all, and hopefully it's helpful. Next slide. And you can go to the next slide. Thank you. All right, so in the handout, I have 3 scenarios in there, and we're gonna start off with scenario number 1 and just do this together. And I've asked Danielle to allow you all to unmute yourselves during this portion of the session, so that way for those who want to verbally speak up and ask questions or respond with their answers verbally, I encourage you all to do so to make this interactive. And then for those that just want to type in their answers, please do so through the chat box, and Danielle will relay the responses, and we'll see how this goes. All right, next slide. All right, directions, so that we're all on the same page. So some of you may be on this session individually and then others in a group. So if you're doing this in a room with a group, I just ask you all to submit 1 answer per group, and then for individuals, it's on your own. So I'll be reading out each scenario to you all out loud, and I'm going to give you all about 1 minute to just absorb and really respond to 3 fields that I want answers for. It's the encounter type, and so that really is, again, the face-to-face, telephone, or offsite. The second ask is, please respond with the service provided in a language other than English. So some of these scenarios will have patients who speak language other than English. Please also specify what that language is. And then the third ask is, please document for us the enabling services type and then time or intensity. And you can either use the full on category, spell it out, or you can just substitute it with the code. So for example, for social services assessment, our code is SS001, and that's again in your handout if you have that available on your desktop or computer. And then please, again, when you respond with your answers, also specify the time. And remember that we're doing this in 10-minute increments. And if you're thinking about rounding up, rounding down, if something is 14, you want to round down to 10. If something is 16, you round up to 20. So again, we're going to try this out virtually. Usually this exercise is done in person in small and large groups. So please bear with me as we go through some of these scenarios. And a reminder, some of you can unmute yourself and verbally answer, and then the others can just chat it in the chat box. All right, let's go for it. So next slide, please. This is scenario number 1. A 42-year-old male patient whose primary language is Vietnamese walked in your health center without an appointment. First, the enabling services provider spends 23 minutes translating between the physician and patient during the exam. He is diagnosed with hypertension and is prescribed medications. After the appointment, the ES provider spends another 18 minutes explaining in Vietnamese a brochure on hypertension that is written in English, discussing the condition and treatment in more detail. So again, read this quickly and try to, in the chat box or verbally, let me know what the encounter type is, the language other than English, and then the enabling services type and minutes spent for each type. So I'm going to give you all about 30 seconds. So we might have some folks who may be able to respond quickly. And if any of you want to unmute yourself, please do. We're encouraging participation in all forms. And if you're typing in your answers, please, type it in, and then Danielle will relay some of the responses. Okay, we're getting some responses in here. I'll give it about 10 more seconds. Okay, seeing a variety of answers here, which is usually the case. And really the important thing to note here is standardization within your health center. That way, within your health center, you have a proper workflow and process as you collect and manage this data on the back end. All right, we're gonna go to the next slide, Danielle, please. So one of you actually got it really correct. It's a face-to-face encounter. The in-language service is in Vietnamese. And then we have 20 minutes for interpretation because of translating between the patient and physician. And then the other 20 minutes is health education, since the enabling services provider was talking about the hypertension and about the hypertension brochure. If you were to just translate the materials on the brochure, then you would code interpretation for 20 minutes. Oops. In any case, thank you all for participating in that scenario. It's really great to see some of you really absorbing this information really quickly. Next one, let's go to scenario number 2. I'll read this aloud again. A 55-year-old Mexican male who is experiencing homelessness came to the health center's mobile medical unit during its weekly rounds at a local church. The ES provider performed a psychosocial assessment, which took 24 minutes. The ES provider also spent 18 minutes talking with him about the challenges related to alcohol dependency, and then 12 minutes talking to him about a supportive housing program. So again, reread it on your end, and once you have a guess, best guess, please type it in, and Danielle will share it with me, and then we'll go over the answer key. And again, 3S, encounter type, any language provided other than English, and then the ES categories and minutes spent. All right, any coming through, Danielle? Okay, we'll give it another minute. All right, we have one answer submitted. I'm just going to read it out loud. This participant said social services assessment, 20 minutes, supportive counseling, 20 minutes, and referral social services, 10 minutes. Okay, and then another person had written counseling and outreach in Spanish for 50 minutes. So I think this person just combined all the enabling services, which is fine if you roll it up, but I think we're looking for really discrete ES codes and intensity or minutes. And then I'll just read one more answer. Face-to-face in Spanish, 20 minutes health education, 10 minutes social and other. All right, let's go to the answer key. So for this, it's face-to-face, and it was actually done in English. So some of you said Spanish, and it could be Spanish, but the scenario itself didn't specify that, so we wouldn't put Spanish in this case. And then the enabling services type and time. We have case management assessment for 20 minutes for the psychosocial assessment, and then you can do health education and supportive counseling for 20 minutes, since the ES provider was talking to the patient about alcohol dependency. And then there's an other that we propose for the supportive housing program, since it's not really talking about a health topic, but really just providing information. And so if you decide to add social case management, treatment and facilitation, and social case management referral, you can add 10 minutes. So some of you did actually hit upon the last point around 10 minutes for referral. So variety across the answer spectrum, but the most important key takeaway here is standardization across your health centers based on the implementation guide that we have. So thank you all for participating in that. And I know we're running really low on time, but I'll quickly go over the last scenario and just tell you the answer. So this last scenario, a health education specialist records a radio program on various health topics every week. The recording is 10 minutes long, and this person spends about 90 minutes in preparation for each recording. And answer here is there's no enabling services provided because there's no way of knowing if you have provided your service to specific patients. The caveat here is these radio programs or outreach to the community should still somehow be documented, because you could be using these radio programs or outreach to the community as a way to recruit new patients into your health center. So that suffice to say, what you do outside of your health center wall is very important to ensuring visibility of your health center services. That way you can sustain yourself as a organization. So that's a trick one, but again, since it wasn't linked to a medical encounter or patient, it was not really counting as enabling services visit. All right, let's go to the last section. So we might, if you all need to hop off, please stay on for the office hours, and we'll probably continue just going over a case study around social service assessments and transportation. So let's just quickly go through this. So
thanks so much, Albert. I think while we have everybody, can we do the quick promotions for the next? Yeah, so we'll come back to these awesome case studies that we have prepared for you on social services assessment and transportation, where we really deep dive. So hang in there for that. We'd also like to share our resources with you. We have links to the PRAPARE resources that Michelle was talking about, this really rich resource from AAPCHO on enabling services implementation that you have the kind of abbreviated handout too, but if you really want to get in there and check out AAPCHO's resources, we encourage you to do that. And for transportation and outreach, HOP, Health Outreach Partners, has a lot to offer, so please check this out or follow up with us directly. We will be taking questions and answers. We have office hours for 30 minutes. We can go over those deep dive case studies And also want to make you aware that we've got 3 more learning collaboratives for the Social Determinants of Health Academy coming up. The next one is coming up in March 11th and 25th, same format as this one, same time, 2 p.m. Eastern, 11 a.m. Pacific. And this one is on fostering a healthcare workforce to meet current and emerging needs, and is hosted by the National LGBT Health Education Center, the Association of Clinicians for the Underserved, and the Corporation for Supportive Housing. And we'll really focus on workforce and community health outreach workers, and on collecting sexual orientation and gender identity data, which is now an ES requirement. So this is really going to be another good opportunity, and they are all free and available to health centers, PCAs, anybody who is interested. And also, if we have any PCA, Primary Care Association staff in the audience, we also want to highlight that there's an Enabling Services Summit coming up in Omaha, Nebraska, hosted by the Healthcare Association of Nebraska, in addition to AAPCHO and HOP, NAC, and MHP Salute. So some of the other national cooperative agreements that you've heard from today are going to be there, and we'll be doing this in person for 2 days in April, focused exclusively on enabling services and from the PCA lens. So super excited to invite you to that as well. Check that link out. And then again, we will have a brief evaluation webinar at the end that will be sent to you after this, the office hours today. So please stay with us. We have some questions for you, and we have the case studies to go back to, and we would love to hear from you. Feel free to unmute your mics and talk to us if you prefer that, or use the questions and messaging format. And thank you. I'm sorry, I know we're a little bit over time. And then please feel free to contact us too if there's anything that we'd like to connect you to or clarify. So with that, Albert, I don't know if we want to resume, go back to the case studies and invite everybody there, or Danielle, please let me know if we're getting some participant feedback on whether we'd like to open the mics up and just have a question and answer session, or go through the case studies. It's totally up to participants.
I've opened up the mic for everybody. Anybody who would like to ask questions, please unmute yourselves and you'll be able to do so.
And hi, everyone. This is Joe Lee from AAPCHO. So I know that both Albert and Michelle had to hop off for another meeting, but I'm happy to help answer any other questions that are coming in through the chat. And as Danielle mentioned, if you have any questions that you'd like to ask verbally, please feel free to do so. Speak up. We won't bite. And I'm just going to start answering some of the questions that we received through the chat. And thank you, Danielle, for relaying them. One person had asked what kind of services are encompassed by InReach. So InReach is defined as the provision of services not linked to an existing care plan, and that are aimed at engaging existing patients in order to ensure appropriate and timely care. So some examples that we have listed in the Enabling Services implementation, data collection implementation guide. Some of the examples include telephone calls to patients to encourage cancer screening, calling or even visiting patients who have not been to the health center in a timely manner to encourage them to come in for care. What this does not include is helping existing patients getting signed up for health insurance. This would be considered eligibility assistance and financial counseling, which is another enabling service category, one of the 15 major categories that you'll find in the standardized data collection template. So I hope that answered your question. That was a really great question in terms of what the definition is, and I hope those examples were helpful. And we saw another question come in from Joe, another person named Joe, not myself. Are you seeing any challenges at health centers where enabling services staff may be spread out over multiple directors like finance, operations, and clinical? And also, there's another follow-up question. Are there health centers who have an enabling services director to oversee all service lines to promote standardization and improve data collection? Oh my gosh, Joe, that would be the dream if we had an enabling services director at every health center. I recently, last year, I met an associate director of operations and enabling services at a primary care association, and it was just really great to see a dedicated workforce position for enabling services. And that person's job was to really advocate for standardized enabling services data collection for their member health centers. And I have personally seen, when I used to work at a clinic, lifelong medical care based in Berkeley, California, we had various directors who were responsible for overseeing enabling services. Director of Patient Services, the Chief Operations Officer. We even also had program directors, specific program directors that would lead specific types of enabling services. And in regards to your question, in terms of if there are any challenges at health centers where these directors may be spread across the clinic, yes and no. It really depends on your organizational, your hierarchy, the way the organization is structured. At the clinic that I used to work at, we actually had a standardized direct service report through our AmeriCorps program, where we documented length of engagement and service activities performed, like eligibility assistance, transportation, and which special populations we served, such as folks experiencing homelessness. And we were able to collect this data across multiple departments and multiple clinics. And I was actually the person who drove that standardization process. So you can have a single champion or single director overseeing that process. I know another clinic that we work with in Hawaii, they have a manager of care coordination, and they're currently engaging with their care coordination department for implementing data collection initiatives like PRAPARE, for example. And I know that they have recently met with their other departments, like a Department of Outreach and Department of Behavioral Health, to initiate these data collection programs across the clinics as a whole. And I'll just give one more example. Another clinic that I work with, that we work with in Hawaii, they have their informatics team. Their informatics specialist is really responsible for spearheading and championing these data collection initiatives and providing that training to all providers and directors. And they have made an effort to customize their own enabling services data collection template. And I see that Danielle just posted a sample job description for an enabling services manager. Thank you so much. It looks like a LinkedIn posting there at the White House Clinic. Oh, you're sharing your screen.
Trying
Wonderful.
to pull it up for us currently, yeah.
Oh, thank you. This is perfect. We worked with the White House Clinic before. This is great. Looks like they have an enabling services program manager position. So this is wonderful. And looks like actually Albert had shared that. So thank you, Albert. Looks like he was still online. So you can see the principal duties here. Someone who is responsible for overseeing department operations at multiple clinics. They're really responsible for monitoring different services, departmental spending, conducting team leader evaluations. Let's see, analyzes data to inform departmental decision-making and making recommendations and adjustments as appropriate. So as mentioned earlier by Albert and Michelle in her presentation, having a standardized enabling services data collection process can really help with resource allocation and workforce planning. And this is something that, there's that quote, without data, you're just another person with an opinion. So we love that quote, because I remember when I worked at a clinic, it's like I would advocate for, we need to sustain our veggie giveaway programs. This was a program that we partnered with farmers markets to deliver fresh fruits and vegetables to our patients for free. And when we were at a risk for cutting that program, I demonstrated data in terms of the volume of enabling services around that program and the intensity, the number of minutes delivered, and how many patients we served. And we were able to sustain that program and even expand it.
Looks like we have another question.
Yes.
Looks like it's from Nancy Newberry. Would an assessment of patient activation qualify as a social services assessment?
Let's see, would an assessment of patient activation? I might be misinterpreting. I'm wondering, Nancy, could you describe the process of patient activation, or if any of my colleagues on the line can explain that to me? Assessment of patient activation. So I'll start off with the definition, and for my colleagues, Kristina and anyone else, feel free to jump in. But social services assessment, so this is what we define as a non-medical assessment that includes the use of an acceptable instrument measuring socioeconomic status, wellness, and other non-medical health status. So for example, this is like assessing patient needs like housing, food, transportation, legal needs, education. It does not include assessments for medical health status like cancer screenings and HIV testing. So I am curious to
I'm thinking.
Yeah,
I'm
go for it.
Nancy meant, if I interpret correctly, Nancy, that patient activation might be patient intake, like a new patient enrollment, and if they're asking questions regarding social need, transportation need, and the kinds of things you're talking about, Joe, that would probably qualify as a social services assessment, depending on what their intake forms are like and what kinds of questions you go through with the patient when they.
Yeah, I think so. Yeah, I would say so. I would say so. I think when you're enrolling a new patient, so I mean we have a specific category around eligibility assistance, but that's more focused on really assessing their eligibility for health insurance programs and specific benefits programs. In terms of enrolling into the health center, that's actually a great question. I'm gonna have to look into that more. But I think in terms of enrollment, when we talk about enrollment, we typically target the eligibility assistance and financial counseling enabling services category. And then in terms of other examples of patient activation, I'm not sure if that might fall directly in line with social services assessment. Just the way you described it, Kristina. I think the examples I gave earlier, that might be separate from patient activation. But that's a great question. I'm going to write that down and look into that more. Thank you, Nancy.
Any other questions for anyone? We have questions for you all if the time has come for that, or we're also totally open to go back to those case studies. We have a deeper dive on the social assessment that we're just talking about, or on transportation. So please chat in or speak up if you would like for us to revisit those, or we will wait another minute for questions. Danielle saying no so far.
Kristina, sorry to jump in here. I just Google searched patient activation, and Nancy, feel free to clarify. I just couldn't help but figure out what this means, but it looks like one definition is patient activation as it emphasizes a patient's willingness and ability to take independent actions to manage their health and care. And to see if we can say, like a healthcare provider, if they can assess, the patient's knowledge, skill, and confidence to manage one's own health and healthcare. So in this particular case, I wanna say case management would be an appropriate category for that. So a case management, this would include as an activity, like a specific enabling service activity, like calling a patient to find out the outcome of a referral or next steps that should be taken in the treatment plan. So I hope that would be I hope that's helpful. I feel like case management would be more appropriate, and I see that you sent me your email address, so I will talk to you more about that offline. Another.
Nancy, yeah, there is another one from Lindsay Jensen. Are any of these codes billable? And that is such a great question.
Yes. Gosh, okay. Well, it depends. I guess where you are. You know, so to give a backstory, we created this National Enabling Services Data Collection initiative because of the problem that we have in this country, and that's, you know, our non-clinical services or enabling services, we're not receiving credit for them. There's very little, to my knowledge, to our current knowledge, there's very little opportunities for reimbursement or zero reimbursement. So to, you know, tell you the truth, Lindsay, I'm not sure if any of these codes are billable, but again, I think it depends geographically, because I know there are some alternative payment methodologies happening in some states like Colorado, Washington, and California. You know, we're really looking to transform the way we finance healthcare and the different types of enabling and social services we deliver that really make a big impact on a person's health and well-being. So I'd be really curious to learn from others. I think we have still a good amount of people on this call right now. Please feel free to chat in if you are from a particular state or even county or region where you are able to bill for specific services. Maybe you have an arrangement with your managed services organization or your managed care organization, or maybe you have something set up with your health plan, or does your state adopt something? But gosh, it would be a dream to you know, have all of these codes billable nationally, and which is really why we emphasize the importance of collecting standardized data. And we're just really hoping all of our health centers across the nation will be able to commit to this, so that we can not just demonstrate the importance of our enabling services to our leadership on a local level in our health centers, but also on a policy level, you know, how can we you know, receive that credit and that reimbursement? So that's a great question, Lindsay. Thank you.
I'd definitely like to add to that we have seen some emergence, especially from CMS, so from like the Medicaid managed care types of organizations reimbursing for enabling services. Even Medicare has the non-face-to-face chronic care management codes 99490, and emergence of other of ways to reimburse, and to like acknowledging that, especially in primary care, that there is a lot of work that gets done that isn't reimbursable. So really curious to see what your experiences with that are. Certainly the movement is towards getting those things, finding a little bit of funding for those things and offsetting the costs.
Thank you, Kristina. Great point. Yeah, we should be, let's track that emergence of we should track that, and maybe that could be a resource we can push out.
We're actually working on it.
Oh, nice. Oh, great. Okay, go health outreach partners.
In the early stages. So, but I love the question. Thanks, Lindsay.
Fabulous. Fabulous. Great. And again, for those on the line, if you have, you know, any examples, please do let us know. Oh, Colorado, thank you for chiming in. Health centers receive an enhanced PMPM for care coordination, but not for any other ES activities. I know in Colorado there's a story we like to promote a lot in Colorado. The Valley-wide health system. They do a really I think because of the ES DC data, they were able to. This is a success story that I shared in the last webinar. But they worked with their Colorado Medicaid office to arrange a per member per month or PMPM arrangement to support their care coordination. So I wonder if the person who provided that example is actually from Valley-wide Health Systems. So great. Oh, that was from Joe. Okay, yeah. Great. Hi, Joe. I know you. Great. Thank you, Joe, for that example.
Yeah, and I believe that the CMS, the Medicare codes are also per member per month.
Oh, right.
Yeah, so maybe that's more the model that's getting done, which can be challenging, and also really confirms that need for documentation and using data collection.
I agree. You know, this reminds me, I worked at my last job. I worked at a managed services organization where we had that PMPM arrangement with our local health plans, Medicaid health plans in California, where it's called Medi-Cal. And it really taught us, you know, and the organization, they launched an amazing community health worker program to really address the needs of high-risk patients, and they were really able to drive down ED utilization rates and save costs. And with that PMPM arrangement, anything that we save, you know, that's basically, you know, revenue that we were able to earmark for and allocate that toward more, you know, CHW or other enabling service resources. So I agree. I think this is something that's becoming more popular.
We got one more question from Gabriela Gonzalez. Hi, are enabling services codes discussed today considered dummy procedure codes for documentation and tracking purposes?
They're considered dummy procedure codes for documentation. Yes, yes. So you'll notice that, and if you, Danielle, if you want, if you can go back to the slide that shows those codes. So yes, those are dummy codes, and we had developed them in to ensure that they can be standardized. So we developed our codes with our AAPCHO members, our health centers initially, but later we incorporated wider national input. We did an environmental scan and interviews with health centers to come up with a uniform set of categories across all the sites. And the UDS, you guys will notice, you guys probably know this by now, but UDS provides some definitions, but the health centers chose to develop these categories because, one, they were meaningful to them. Two, they captured the majority of additional services they provide. And three, they would not be burdensome to implement or collect data on. So the modified set of codes that you see right here in the categories, they were developed to really incorporate more of the social interventions that are actually taking place. And we had a larger group of stakeholders to help us inform these categories, including NAC, National Healthcare for the Homeless Council, and health outreach partners. So these are dummy procedure codes, and we encourage you to utilize them and embed them in your EHRs. I think one thing, I'm not sure if this was mentioned, I forget if this was mentioned earlier, but in terms of electronic health record systems, so we have EHR enabling services templates available for 4 EHR vendors: GE Centricity, ECW, NextGen, and Epic. And some health center organizations may need or may want to create their own template to monitor their own templates if they don't have these EHR vendors that I mentioned. You just got to ensure that the response items are as standardized as possible. So just following the standardized questions that you'll find in a toolkit. Keep in mind those who have ECW, NextGen, GE Centricity, or Epic. These were enabling EHR enabling services templates that were developed as a part of the PRAPARE rollout. So they might be old. You might find them to be old enabling services categories. These categories that you see right here on this slide and the next slide, these are the newer 15 revised categories that were launched as of 2017. So please keep that in mind. We encourage you to use all 15, and if you have more enabling services categories, plug in more. That's why we put in the other there. And some health centers love tracking way more enabling services. And yeah, this is hopefully a resource that will be helpful to you. Thanks, Gabriella. Great question. Great. Okay, looks like there are no other questions so far. Kristina, we have about 6 minutes left and still a good amount of folks on. Should we try going to some of those case studies?
Yeah, absolutely. Here, let me get us back to those.
Let's do it.
Sorry, there's no better way than just click through. Okay, to the case studies. And I think that this was AAPCHO prepared for the social services assessment. I can do this one, or I'm happy to jump into the transportation one.
Yeah, go for it. I'm down for either.
Do we have any requests on behalf of the participants? We have one focused on social services assessment and one focused on transportation, and really using that enabling services data and how to respond to transportation needs.
Yes, chat in your votes. What do you want to know about?
Hearing
what
crickets.
And I'm happy to just share really quickly the social services assessment. So if you go to the next slide, Danielle, that'd be fabulous. So this is one of our health centers, a Charles B. Wong Community Health Center based in New York. You can go to the next slide. They were part of our Enabling Services pilot project back in 2004. I think it's the next slide. Yes, thank you. So the social work department at Charles B. Wong, this was a template that they had created for enabling services data collection. And you'll see that they created specific taxonomies to capture the services delivered at the end of their encounters for biopsychosocial assessments. And they, in 2017, they were able to measure that they delivered over 22,000 units of enabling services for approximately 11,000 patients. And they, their top 3 enabling services they found were case management, treatment, and facilitation, which on average, it took about 17 minutes to deliver, and then case management assessment, and then referrals. So this is just a really quick example of how a health center has used enabling services data collection. They built the tool in their EHRs and the results they got to inform their resource allocation and workforce planning. And then, Kristina, do you want to go for the transportation?
Sure thing. Okay, moving right along. So transportation is something that we get a lot of requests for more information about from our health centers that we work with and PCAs as well. So we're just going to go over a quick transportation case study. This is actually adapted from a real life case study, real health center in upstate New York in the Finger Lakes region. We just modified it a little, so didn't want to kind of, you know, modified it, adapted it to make it a generic case study. But it's from our transportation models that work resource, which is available to all health centers and PCAs for free online, so please check it out. In this particular example, we're in a really rural area, upstate New York, with a large agricultural economy, including grapes, apples, cabbage. And this health center has migrant health center funding, PHS 338G funding to serve migratory and seasonal agricultural workers who live in camps that serve these this agricultural economy and these farms upstate in really largely isolated areas with very few transportation options. So in this case, this health center, this is the part that's fabricated and just adapted. I don't know what this health center really uses, but in this example, we're using a paper form, which, you know, there are advantages to using electronic data collection, but in some cases it might be easier or more appropriate to use paper forms for health center. So in this case, they're using PRAPARE paper, and they're identifying questions 14 and 15, as you see here, that this particular patient is really having issues where they're not able to access healthcare when they need it. And they check yes, you know, lack of transportation for medical appointments, meetings, work, and getting to and from daily living kinds of things that they need to do, that transportation has prevented them from being able to keep medical appointments and doing these things that they need to do in their life. And so this information is aggregated by the health center. Maybe if they're using paper forms, they're entering it to an Excel spreadsheet or doing some other lower technology function, not using a very complex system here, but they're finding out that people have a lot of transportation needs from this PRAPARE template, and they collect this information and decide they need to do something about the transportation challenges in this area, especially because there's limited or non-existent public transportation, and people's access to personal vehicles is also very limited, and also driver's licenses are required to drive, and that can be a prohibiting factor in getting access to a car to get to a medical appointment, and all of these options are expensive for patients. So the health center decides to take action, and in real life, this health center did, and they really use all 4 of the different categories of tools available to them to address transportation issues. The first being providing services directly, having case managers or other enabling services staff actually, use vans or use their personal vehicles and get reimbursed, who are bicultural and bilingual or multilingual, and really are able to meet the patients where they are and go get them at the camps or at their work site or at a place convenient for them and bringing them into the health center. So that's one model that works for some health centers. Additionally, if the health center in this case had the resources to provide mobile outreach and met the patients where they were, either at their camp or work site, they are able to provide some services in a van or a mobile clinic of some kind and see a fair number of patients a day that way. And then also find people who might have more advanced medical needs and need to come into the actual practice or get a referral and get linked up to those transportation services, those direct services that we just mentioned, in order to be able to meet their medical needs. So that's one way of reaching people as well. Additionally, place-based care is another way that can be really effective for health centers to meet transportation needs. In this case, working with a migrant Head Start site. So if you're providing care at a school that's serving migratory and seasonal agricultural worker children, then you're maybe getting their parents as well and getting them into these clinics and being able to provide some health care at a place where they're already going to pick up their kids or to give their kids, in this case, health or dental care in a way that is really convenient and works into their lives and can really mitigate some of those transportation barriers and challenges. And then lastly, kind of taking the transportation piece out of it altogether, providing telehealth where technology permits by phone or by secure electronic messaging. And EHRs can facilitate this really well, but there are lower tech options for just over the phone as well, ways to provide care and to connect people and refer people to care. And using bilingual and bicultural staff and those outreach staff or promotores and ways that can really reach people where they are more effectively and connect people to care. So those are just very broadly some ways in which people can address health centers address transportation barriers, and we have extensive solutions and resources and different things for you to read and that are free to health centers on our website, and I'm happy to answer any questions offline. You have my contact information. So I know we're right at 12:30 and Danielle had to sign off, but I think if attendees are still here, if anyone has any questions and wants to unmute themselves, we'll be able to hear you that way.
Thank you, Kristina. That was really great. Before folks log off, we just want to bring your attention to these wonderful resources that you see in front of you. If you want to learn more about the PRAPARE initiative and the enabling services implementation toolkit, as well as the transportation and health access QI toolkit developed by health outreach partners and the outreach starter kit, please visit these links and download them. These resources are free, and you're highly encouraged to reach out to us for questions and for more training and technical assistance opportunities.
And thank you, Joe. Joe wants to say Valley-wide has a robust mobile unit program for ag workers and primary care for dental and for flu shots. And I was really lucky to meet some community health workers at Valley-wide at the Midwest last year. And yeah, I was very impressed. It was really awesome to talk to your colleagues. So thanks for sharing that. I think it can be really effective.
That's great. Thanks, Joe. And the other Joe, not me.
Yeah. Thank you both, Joes. Okay. Well, please do feel free to reach out to us and leaving our contact information up here with all of our emails. We have a bunch of free resources for health centers that as we've been saying, would love to connect you all to. So please reach out.
Okay, great. Thank you, everyone. Have a great rest of the day and a great rest of the week. Take care.
Thank you so much. Bye. Take care.